of herpes simplex virus, TB uveitis. So topical steroid, for example, prednisolone acetate 1% 4 times daily, and topical cycloplegics in combination with the oral antiviral, for example, acyclovir 400 milligram 5 times a daily. So basically, whenever there is a uveitis, you have to give the steroids. So as it is antiviral and with topical steroids, if there is no corneal involvement and there is no epithelial defect, and then you give the oral antiviral, which is 400 milligram 5 times a day acyclovir. There is an evidence that famciclovir or valcyclovir is better tolerated than acyclovir. Steroid may be delayed and used with caution if active epithelial disease is present, and when a topical antiviral may be added. So whenever there is an epithelial defect, first you have to give topical antiviral, and after sometimes you can use the topical steroid when the disease heal. Raised IOP is treated. Raised IOP is treated as necessary. Next is a varicella zoster virus interior uveitis. Introduction. Interior uveitis of variable severity occur in around 50% of the patient with herpes zoster ophthalmicus (HCO) and generally starts 1 to 3 weeks after an acute skin rash, occasionally in a patient with HCO without dermatitis, zoster sign herpetica. So whenever there is a no herpes zoster ophthalmicus, but there is no dermatome involved, this is known as a zoster sign herpetica, and uveitis occur after 1 to 3 weeks after the skin rash. Zoster associated iridocyclitis may be recurrent when diagnosis is usually straightforward due to the past history of the ipsilateral HCO. So it is a recurrent uveitis. As with the herpes simplex, signs may be of a granulomatous inflammation. So sectoral iris atrophy is often present, corneal sensation may be reduced, and IOP is raised. So some of the findings are there going to be the sectoral iris atrophy, they're going to do the reduced corneal sensation, and they're going to be the raised IOP. PCR analysis of aqueous is indicated exceptionally. Anterior segment inflammation can occur in primary VZV infection, chickenpox, particularly in the immunocompromised. Neuroretinitis is rare. Uveitis has been reported following VZV vaccination. So treatment are the same. Topical steroid and mydriatic in addition to standard systemic antiviral treatment of shingles. Systemic steroids are required rarely. For example, optic neuritis. All patients with HCO must be monitored by an ophthalmologist depending on the severity. So basically, the treatment is same. You give topical steroid, you give oral acyclovir, and you can give only the steroid, oral steroid when there is an optic neuritis. For example, up to weekly for at least 6 weeks to detect occult ocular inflammation, and subsequently possibly long term to detect late complications. So if a patient with the HCO uh, presents to you, you have to monitor them 6 weekly to detect any ocular inflammation and then long term follow. Persistence or recurrence of anterior uveitis may respond to a week-long course of a acyclovir 800 milligram 5 times a daily, and long-term systemic antiviral prophylactic treatment can be considered for repeated recurrences. VZV vaccination offers protection against the shingles. So you can also give, if there is an acute inflammation, you can give 800 milligram 5 times daily in a VZV uveitis. So you can see 12.55 is showing iris atrophy in herpes simplex anterior uveitis, and B is showing sectoral iris atrophy in herpes zoster anterior uveitis. Cytomegalo virus interior uveitis. Introduction. CMV iridocyclitis in the immunocompetent is the more common than previously realized, albeit still less prevalent than HSP and VCV related inflammation. It may be recurrent or chronic and unilateral or bilateral. Elevated IOP is very common. CVMV has been reported as a cause of a Posner-Skolosman syndrome. Little or no ciliary injection, limited flare, few cells, corneal endotheliitis, cases of a range of morphology, and sectoral iris atrophy has been reported. So CMV also causes the interior uveitis, but in that case, IOP, it can be acute, it can be chronic, it can be unilateral, it can be bilateral. IOP is common, and it is one of the CME is one of the cases that has been associated with the Posner-Skolosman syndrome. And there are going to be few ciliary injection, there is going to be limited flare, few cells, there are going to be corneal endothelitis, there can be KPs, there can be sectoral atrophy. Posterior synechiae are rare. A key diagnostic indicator in some cases only may be a failure to respond to acyclovir and or steroid. PCR and antibody assay of a echo sample should be considered if there is a clinical suspicion. So CMV is treated with a ganciclovir. So ganciclovir. So oral valganciclovir has a proven infection which sometimes require long-term continuation. IOP elevation may be persistent. So next is the rubella. What rubella causes uveitis? Rubella, German measles, is a common childhood infection and usually follows a benign and a short-lived course. However, transplacental transmission of virus to fetus from an infected mother can lead to congenital abnormalities of a multiple organ system. So whenever a fetus has been infected during transplacental, it can cause congenital abnormalities with severity generally worse than earlier in gestation infection occur. Latent rubella virus may cause chronic anterior uveitis relatively unresponsive to steroid and has been implicated in the causation of the Fuchs uveitis syndrome. So CMV was associated with Posner and rubella is associated with Fuchs uveitis syndrome. Very important for the MCQ's point of view. Reported ocular features of the congenital rubella include cataract, anterior uveitis, salt and pepper pigmentary retinopathy, glaucoma, and microphthalmos. So remember, cataract, uveitis, and salt and pepper pigmentary retinopathy. So next is so we can see figure 12.56a is showing us rubella retinopathy, A is showing salt and pepper appearance, and B is showing predominantly manifestation in the macula. Next is the measles. Congenital infection with the measles virus can cause spontaneous abortion or congenital systemic and ocular anomalies, including cataract and retinopathy. So, measles can cause cataract and retinopathy. Infection acquired in childhood typically features conjunctivitis and epithelial keratitis. Occasionally, retinitis with macular and disc edema can occur. Subacute sclerosing encephalitis is a late complication of a measles infection manifesting with a chronic progressive neurodegenerative and usually fatal disease of the childhood caused by measles virus. So measles virus causes SSPE, which is the subacute sclerosing panencephalitis, and basically it is a progressive neurodegenerative disease. Posterior uveitis is common and may be the presenting feature. Then so you can see 12.57 is showing posterior uveitis. Retinal involvement in subacute sclerosing and encephalitis. Next is mumps. Iridocyclitis and interstitial keratitis are rare complications of mumps, so it also causes uveitis, mumps. Vaccinia is also a virus. Smallpox vaccination using vaccinia virus has resumed for some group as a result of a perceived risk of bioterrorism. Though rare, a range of anterior segment manifestation has been described both from auto-inoculation in vaccine and in close contact. So basically, this is due to the vaccination of a smallpox vaccine, and it also causes some kind of anterior segment inflammations. So Zika virus is transmitted by an infected Aedes mosquito, which also causes the dengue. The virus can be passed from a pregnant woman to her fetus. So whenever a pregnant mother is getting um, in bite, so she can pass her to fetus, resulting in significant birth defects, including microcephaly. In congenital Zika, ocular effects include chorioretinal and macular atrophy, focal pigmentary changes in the macular region. So basically, you can see the chorioretinal and macular atrophy. There can be the pigmentary changes in macular region. There can be the optic nerve abnormality and glaucoma. In adults with an acute infection, conjunctivitis is the most common ocular manifestation, followed by uveitis. So first there is going to be conjunctivitis, then there is going to be uveitis in case of a Zika. The virus may persist in the lacrimal gland and in other tissue of the eye, particularly in retinal pigment epithelium. Next is the Ebola. The Ebola virus, which is responsible for the epidemic in West Africa, has the potential to cause clinical disease in sporadic outbreaks. In survivor post Ebola virus disease syndrome, PEV-DS, may result in ocular disease, arthritis, hearing loss, abdominal pain, and neuropsychiatric disorder. So, post Ebola virus disease can cause diseases of the eyes, ocular disease can cause arthritis, can cause hearing loss, abdominal pain, and neuropsychiatric disorders. Uveitis occur in up to third of the survivors and may result in acute or chronic visual loss. This can manifest as anterior, posterior, or pan uveitis. So, Ebola virus can cause pan uveitis, it can cause anterior uveitis and posterior uveitis as well, with most cases occurring within 2 months of discharge, up to 15% subsequently developing a cataract. Optic nerve swelling has been reported to occur in 10% of the survivors. The virus has been detected in the aqueous in the acute situation and can infect and persist in the retinal pigment epithelial cells. So these are basically affecting the RPE cells. Treatment is with topical and oral corticosteroid is affected but needs to be started at the onset of symptoms to prevent the long-term visual loss. So that's it for the uveitis part 11. See you in the next lecture.